Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
Have you ever had pain in your heel that it seems to last forever and it makes it hard to walk? It's usually in the front of your heel, and it's usually worse when you get up in the morning or you take the first few steps. You ever had it?
No, I have not, but I do know people who have.
Well, and you know what the likely diagnosis is? Well, it's called plantar fasciitis. It's an inflammation of the fibrous tissue that is on the sole of your foot that connects the heel bone down to the toes. The problem with it is it's hard to treat, and some patients get some relief from physical therapy. Some get a little relief from inserts in their shoes or what's called a heel cup or a heel pad. Night splints sometimes, anti-inflammatory medication, or sometimes an injection. Can you imagine an injection in the heel? Not much fun.
But sometimes none of it works.
Exactly.
Are you kidding me? Oh, well, there's good news for people who've been suffering from plantar fasciitis for a long time, and can get relief no matter what they try. It's a minimally invasive treatment using ultrasound. It's a minimally invasive treatment using ultrasonic energy. Presto!
Yeah, ultrasound.
Here to discuss this new treatment option for plantar fasciitis is physical medicine and rehabilitation physician Dr. Jay Smith. Welcome back to the program, Dr. Smith. Good to see you.
Oh, thanks, Tracy. Thanks, Tom.
Dr. Jay Smith, you got the ticket for curing plantar fasciitis?
Well, I'm not sure I have the ticket, but we certainly have a tool that wasn't available more than 7 years ago that's really helped us help a lot of patients who've had refractory symptoms.
So tell us how it works.
So the idea of this particular device is that it uses ultrasound energy to vibrate a very small hollow tip needle, and it emulsifies tissue in its pathway. So it basically turns the degenerated, torn tissue to jelly, and then it sucks it out, sort of like a power washer, taking the paint off your wall. And we use this device under ultrasound through a very small incision, about 2 to 3 millimeters incision in the skin. We move the device under ultrasound into the plantar fascia under local anesthesia. And once we activate the device, the needle moves back and forth and does its job. The whole procedure takes maybe a minute or two once we're going.
Wait a minute. So you are taking it out?
Mm-hmm.
Before you had this, how did people recover from plantar fasciitis?
Well, many people, in fact, most people do recover spontaneously, but it can take a long time. Many people have had symptoms for 6 months, 12 months or more. About 10 to 20% of people will have symptoms that just don't respond to the usual things like Tom had mentioned for treatments. And in those cases, surgery would be a consideration in which our surgical colleagues may cut part of the plantar fascia to relieve the tension on the plantar fascia and the stress on it. Sometimes a piece of the plantar fascia would be removed. The idea behind the surgery is basically to try to get rid of the damaged tissue. Mm-hmm. Our job was, or our task was to develop a way to do that through the skin without having to cut down to it. So to basically simulate the surgical procedure without having to do the surgery itself per se.
It's interesting, isn't it, that removing the damaged tissue relieves the pain?
Yeah, admittedly, in many cases, we're not sure exactly where the pain is coming from. Despite all the tendinitis and fasciitis and all the other itises we have in the body, many times we're not sure exactly where the pain is coming from, but certainly taking the damaged tissue out does seem to correlate with improving people's pain. So that's been the traditional target. And again, I equate it to taking off the old paint on a wall before you put new paint. If you take out the bad tissue, this degenerated, inflamed tissue, your body then is stimulated to heal it the correct way. Now, you injured it at some time, whether it was a single event or over time, you injured the plantar fascia, it became inflamed. It tried to heal, but it didn't do the job. It couldn't do the job. So what it did was fill itself in with scar tissue. And that scar tissue doesn't really do its job very well, and that's why it hurts when you try to do things. So you take out the bad tissue and take a step backward and then promote the normal healing, and that's how the process works.
Is this a diagnosis that you can make on clinical exam, or do you have to do another test to make sure you've got the right diagnosis before you do the procedure?
Almost always plantar fasciitis can be made as a clinical diagnosis. As you mentioned, people have heel pain. They have pain in the morning. It hurts right at the bottom of the heel. There are a few other conditions certainly that can mimic plantar fasciitis. Some people will have stress fractures in their heel bone. Some people will just have inflammation of the fat pad, your shock absorber on the bottom of your foot. But most often imaging is not needed to make the diagnosis and initiate initial treatment. For our particular procedure, we are using ultrasound to image the plantar fascia. We can see the plantar fascia very well under ultrasound. We can see how much it is damaged and make a diagnosis that way without needing to resort to MRI. And of course, we use that same ultrasound to do the procedure.
Is the problem that led you to have the plantar fasciitis in the first place, is that likely to reoccur?
Well, there is
even though you've had it fixed with this new
it's a
technique?
very good question. The recurrence rates have not been particularly high with the procedures, so we do feel that we're taking care of the problem. Part of it, of course, just like any surgery or surgical intervention, is to try to identify the risk factors and modify them. So if there's something about someone's biomechanics, or maybe they're carrying a little bit too much weight, or maybe they're not wearing the right size shoes, or shock-absorbing shoes, we will fix that as part of our treatment. We want to treat the whole patient and not just the plantar fascia. So that is an important part of what we do.
So why some people and not others? You mentioned obesity as one of the risk factors. Are there others?
So risk factors that have been documented, certainly excessive body weight, because the more pressure you put on your heel, the more pounding it takes.
Sure.
And secondly, people who are on their feet more than 8 to 10 hours a day statistically have a little bit of a higher risk of plantar fasciitis. People who have tightness in their Achilles tendons and their plantar fascia will have more tendency to get plantar fasciitis, because your plantar fascia is basically a shock absorber, and it recoils. When you step down, your plantar fascia elongates and then it recoils. If it's too tight and it doesn't work, then it may break down on you. So those are the primary risk factors for most people.
One other quick question about it. You will often hear people say that they had an x-ray and they have a heel spur, but it's rarely the spur that's causing the pain, right? The
Yes.
spur is secondary to the plantar fasciitis?
Correct. It's a very glad that you brought that up. The bone spur is just a secondary sign of the tension in the area. The pain is not usually coming from the bone spur, almost never coming from the bone spur. There are certainly cases where the bone spur can fracture, but they're very rare. The important thing is that the bone spur doesn't need to be taken out for someone to have clinical relief, and that's the important point to make.
And how was Mayo Clinic involved in the development of this procedure?
Well, my partner, Dr. Barnes, who's a family medicine, sports medicine practitioner in Austin in the Mayo Health System, and I, as well as some other colleagues, developed the technology. We adopted it from some pre-existing technology in the ophthalmology world, a process called phacoemulsification, and they use similar technology, believe it or not, to take cataracts out of an eyeball, and we felt that if you could stick it in an eye, you could probably stick it in the plantar fascia. So through Mayo's assistance, we modified the technology and developed it for this purpose.
Wow. Well, since the last time you were on this program, Dr. Smith, we are on over 140 radio stations.
Oh, my goodness, yeah.
So you are throwing a wide net out there, and people who are suffering from plantar fasciitis are probably thinking, what?
Right,
So
right.
is this, are there other physicians across the country that are interested in what you're learning?
Yeah, there are several hundred physicians across the country that perform this procedure, which is called different names, but most people call it a percutaneous ultrasonic fasciotomy. The company that markets the device is called Tenex, T-E-N-E-X, and you would be able to ask your practitioner if they're familiar with that procedure.
How many have you done?
Probably 200 by now, and certainly there are people that are doing more volumes than that, but most of our practitioners across the country, most of my colleagues who are doing it have done several hundred. There have been over 40,000 procedures done nationally. Of course, not all those are for plantar fascia. This device is also used for tendonitis, so it's used in the Achilles tendon, it's used for tennis elbow, and now rotator cuff disease. So when you consider all the procedures that have been done, over 40,000 have been done in the United States.
All right, so percutaneous ultrasound fasciotomy.
Yep.
You want the PUF procedure.
The PUF procedure,
Yeah,
that's a good one. Copyright that, right? So.
All right, rehabilitation specialist Dr. Jay Smith, thanks so much for telling us about the new treatment for recalcitrant plantar fasciitis. Thanks, Jay.
Thanks for having me. Yes.